Today let's see the disease of vitreous. Plate anatomy. Vitreous is an inert, transparent, jelly-like structure that fills the posterior four-fifth of the cavity of eyeball. Vitreous body is somewhat spherical posteriorly and has a cup-shaped depression anteriorly. Posteriorly it is spherical, anteriorly it is cup-shaped. Thus it conforms to be contour of retina behind and lens in front. It is about 4 ml in volume and 4 gram in weight. Functions: the hydrophilic gel that mainly serves the optical functions. In addition, it mechanically stabilizes the volume of the globe and is a pathway for nutrients. Embryologically, this vitreous body is secondary or definitive vitreous secreted by neuroectoderm of optic cup. During development, when this secondary vitreous fills the cavity, primary or primitive vitreous along the hyaloid vessel is pushed anteriorly and ultimately disappear. Tertiary vitreous developed from the neuroectoderm in the ciliary region and is represented by the ciliary granules structure. The normal youthful vitreous gel is composed of a network of randomly oriented collagen fibers interspersed with numerous spheroidal macromolecules of hyaluronic acid. Collapse of the structure with age or otherwise leads to conversion of gel into salt. The vitreous body can be divided into two parts, the cortex and medulla. Or nucleus. The cortical vitreous. It lies adjacent to the retina posteriorly and ciliary body, granules and lens anteriorly. The density of collagen fibrils is greater in the peripheral part. The condensation of these fibrils form a false anatomic membrane which is called as anterior hyaloid membrane anterior to ora serrata and posterior hyaloid membrane posterior to ora serrata. The attachment of anterior hyaloid membrane to posterior lens surface is firm in young and weak in elders, whereas posterior hyaloid membrane remains loosely attached to internal limiting membrane of retina throughout the life. These membranes cannot be discerned in a normal eye unless the lens has been extracted and posterior vitreous detachment has occurred. The main vitreous body medulla or nucleus, it has a less dense fibrillar structure and is a true biological gel. It is here where liquefactions of vitreous gel start first. Microscopically, the vitreous body is homogeneous but exhibits wavy lines as of water silk in the slit lamp beams running down the center of the vitreous body from the optic disc to posterior pole of the lens is hyaloid canal. This is ora serrata. This is cloquet canal, posterior hyaloid membrane, vitreous base, anterior hyaloid membrane, space of Bidger, Weger ligament, ora serrata. Attachment: the part of vitreous about 4 mm across the ora serrata is called vitreous base. Across the ora serrata, where the attachment of vitreous is strongest. The other firm attachments are around the margins of optic disc, foveal region and back of versatile lens by hyaloidocapsular ligament of Weger. Disorders of vitreous. Vitreous liquefaction is the most common degenerative change in the vitreous. Causes of liquefaction include age-related liquefaction is of common occurrence after the age of 50. Degenerates such as myopic degeneration that associated with retinitis pigmentosa. Post-inflammatory, particularly following uveitis. Trauma to vitreous may be mechanical. Thermal effects on vitreous may following diathermy, photocoagulation, cryocoagulation. Radiation effects may also cause liquefaction. Clinical feature: on slit lamp biomicroscopy, the vitreous liquefaction is characterized by absence of normal fine fibrillar structure and visible pockets of liquefaction associated with appearance of coarse aggregate material which moves freely in the free vitreous. Liquefaction is usually associated with collapse and opacities in the vitreous. Vitreous detachment. Posterior vitreous detachment. It refers to separation of cortical vitreous from the retina anywhere posterior to vitreous space. Posterior vitreous detachment with vitreous liquefaction, synechiasis or collapse. Synechiasis is of common occurrence in majority of normal subjects above age 65 years. occurs in eyes with senile liquefaction, developing a hole in the posterior hyaloid membrane. The syncytic fluid collects between the posterior hyaloid membrane and internal limiting membrane and retina, leads to PVD up to base along with collapse of remaining vitreous gel. These changes occur more frequently in the aphakic conditions than phakics and in myopes than emetropes. Clinical feature: flashes of light and floaters are often associated with PVD. Vitreous syneresis, posterior vitreous detachment, and syncytic fluid. Biomicroscope examination of vitreous reveals a collapsed vitreous syneresis behind the lens, and an optically clear space between detached posterior hyaloid face and retina. Ring-like opacity, Weiss ring or Fuchs ring, representing a ring of attachment of vitreous to the optic disc, is pathognomic of PVD. Complication of Pvd. These include retinal breaks, vitreous hemorrhage, retinal hemorrhages, and cystine maculopathy. Management: uncomplicated PVD requires no treatment. Just reassure but give retinal detachment warning. That is to report immediately on noticing an increase in floaters or flashing lights or appearance of persistent curtain or shadow in field of vision. Retinal tear complicating PVD may need to be treated by laser photocoagulation. Vitreous hemorrhage complicating PVD needs to be managed. Hemorrhage. Let's see about in next page. Retinal detachment complicating PVD requires urgent treatment. Detachment of vitreous base and anterior vitreous. It may occur following blunt trauma. It may associate with vitreous hemorrhage, anti-retinal dialysis, dislocation of crystalline line, vitreous opacities. Since vitreous is a transparent structure, any related non-transparent structure present in it will form an opacity and cause floaters. Common conditions are muscae volitantis. These are physiological opacities and represent residues of primitive hyaloid vasculature. Patient perceives them as fine dots and filaments which often drift in and out of field vision against a bright background. Persistent hyperplastic primary vitreous PHPV. It results from failure of primary vitreous structure to regress combined with hypoplasia of posterior portion of vascular measure. Clinical feature: PHPV may be anterior or posterior, most often elements of both are present. Common features are leukocoria. Whitish pupillary reflex is most common presenting feature of both anterior and posterior PHPV. Microphthalmia is often associated with PHPV. Tractional microphthalmia, the eyeball becomes small. Tractional retinal detachment and retinal folds are features of posterior PHPV. Associated anomalies include congenital cataract, shallow anterior chamber, angle closure glaucoma, long ciliary process, etc. PHP is almost always unilateral. Bilateral cases are rare and may associate with trisomy 13 Patau syndrome, 22 trisomy, Norris disease, Walker-Warburg syndrome. Differential diagnosis need to be made from other causes of leukocoria, especially retinoblastoma, congenital cataract, and retinopathy of prematurity. Computerized tomography scanning helps in diagnosis by presence of calcification in retinoblastoma. Treatment consists of pars plana lensectomy and excision of membranes with anterior vitrectomy. Provided with diagnosis is made early. Visual prognosis is often poor. Inflammatory vitreous opacities. These consist of exudates into vitreous in patients with anterior uveitis, posterior uveitis, pars planatis, pars uveitis, endophthalmitis, vitreous aggregates, and condensation liquefaction. It is commonest cause of vitreous opacities. Condensation of collagen fiber network is a feature of vitreous degeneration which may be senile, myopic, post-traumatic, post-inflammatory in origin. It is a rare condition in which the amyloid degeneration. It is a rare condition in which amorphous amyloid matrix deposit in the vitreous as a part of generalized amyloidosis. These vitreous opacities are linear with footplate attachment to retina and posterior lens surface. Asteroid hyalosis. It is characterized by small white rounded bodies suspended in the vitreous gel. These are formed due to accumulation of calcium containing lipids. Asteroid hyalosis is a unilateral asymptomatic condition usually seen in old patients with healthy vitreous. There is a genetic relation between this condition, diabetes, and hypercholesteremia. Synechiasis sintalis, cholesterol bulbi. In this condition, it is ridden with small white angular crystalline bodies formed of cholesterol. It affects the damaged eyes which have suffered from trauma, vitreous hemorrhage, or inflammatory disease in past. In this condition, vitreous is liquid and so that crystals sink to bottom but are stirred up with every moment to settle down against every pass. This phenomenon appears as a beautiful shower of golden rain on ophthalmoscopic examination. Since the condition occurs in a damage, it may occur at any age. Red cell opacity. These are caused by small vitreous hemorrhages or leftouts of massive vitreous hemorrhage. Tumor cell opacities. These may be seen as free-floating opacity in some patients with retinoblastoma, reticulum cell sarcoma, intraocular lymphomas. Vitreous hemorrhage. Vitreous hemorrhage usually occurs from retinal vessels and may present a pre-retinal, subhyaloid or intraocular hemorrhage. Intraocular hemorrhage may involve anterior, middle and posterior of the whole of the vitreous. Causes of vitreous hemorrhage are retinal tear, PVD and RD may have associated vitreous hemorrhage. Trauma to eye, which may be blunt or perforating. Inflammatory disease such as erosion of the vessels in acute chorioretinitis, periphlebitis, retinae primary or secondary to uveitis, vascular disorders, hypertensive retinopathy and central retinal vein occlusion, metabolic disease such as diabetic retinopathy, oxidative age-related macular degeneration, usually high CN-VM may have vitreous hemorrhage, blood dyscrasias. Example: retinopathy of anemia, leukemia, polycythemia, sickle cell retinopathy, bleeding disorder, purpura, hemophilia, scurvy, neoplasm. Vitreous hemorrhage may occur rupture of vessel due to acute necrosis in tumors like retinoblastoma, malignant melanoma of choroid. Other causes include Coats disease, radiation retinopathy, retinal capillary aneurysm. Clinical feature: anterior vitreous hemorrhage, mild vitreous hemorrhage, posterior vitreous hemorrhage, total vitreous hemorrhage. Symptoms: flutters of sudden onset when vitreous hemorrhage is small, sudden blindness, loss of vision. Signs: distant direct ophthalmoscope reveals black shadows against red glow in small hemorrhages and no red glow in a large hemorrhage. Direct and indirect ophthalmoscope may show presence of blood in vitreous cavity in small vitreous hemorrhage and non-visualization of fluentus in large vitreous hemorrhage. Slit lamp examination shows normal anterior segment and reddish mass in vitreous. Ultrasonography with B scan is particularly helpful in diagnosing vitreous hemorrhage. Fate of vitreous hemorrhage: complete absorption may occur without organization and vitreous become clear within 4 to 8 weeks. Organization of hemorrhage with formation of yellowish white debris occurs in persistent or recurrent bleeding. Complications like vitreous liquefaction, degeneration, Kaposi cell glaucoma may occur. Retinitis proliferans may occur, which may be complicated by tractional retinal detachment. Treatment: conservative treatment consists of bed rest, elevation of patient's head. This will allow blood to settle down. Treatment of cause: once the blood settles down, the indirect ophthalmoscope should be performed to locate and further manage the causative lesions such as retinal break, phlebitis, proliferative retinopathy. Vitrectomy by pars plana route should be considered to clear vitreous if the hemorrhage is not absorbed after 3 months. Early vitrectomy may be required when associated with retinal detachment. Vitrectomy. Surgical removal of vitreous is known as frequently known as vitrectomy. Common terms used in relation to vitrectomy are anterior vitrectomy, core vitrectomy, and subtotal vitrectomy. Anterior vitrectomy refers to removal of anterior part of vitreous. Core vitrectomy refers to removal of central bulk of vitreous. Subtotal and total vitrectomy, in this almost whole of the vitreous is removed. Techniques: open sky vitrectomy. This technique is employed to perform only anterior vitrectomy. Indication: vitreous loss during cataract extraction, AFAK keratoplasty, anterior chamber reconstruction after performing trauma with vitreous loss, removal of subluxator and anti-dislocator lens. Surgical technique: open sky vitrectomy is performed through primary wound to manage the disturbed vitreous during cataract surgery or AFAK keratoplasty. It should be performed using automated vitrectomy machine. However, if the vitrectomy machine is not available, it can be performed with help of triangular cello sponge or De Vicker scissor. Closed vitrectomy: pars plana vitrectomy. Pars plana approach employed to perform anterior vitrectomy, core vitrectomy, subtotal and total vitrectomy. Indication: endophthalmitis with vitreous abscess, vitreous hemorrhage, Proliferative retinopathy such as diabetes, associated with diabetes, Ehlers disease, retinopathy of premature retinitis proliferans, complication and case of retinal detachment such as those associated with giant retinal tears, retinal dialysis, massive vitreous reaction. Presently, even simple case of rhegmatogenous retinal detachment are managed with this technique. Removal of intraocular foreign bodies, removal of dropped nucleus or intraocular ends from vitreous cavity, persistent primary hyperplastic vitreous membranes and bands, macular pathology like macular hole, epiretinal membrane. Surgical techniques. Pars plana vitrectomy is highly sophisticated microsurgery performed by using two types of system: one port vitrectomy or full function system vitrectomy, three port pars plana vitrectomy, divided system approach. It is used nowadays. It employs a multifunction system that comprises vitreous infusion, suction, cutter, and illumination. Three-port pars plana vitrectomy is most commonly employed technique in modern vitrectomy. In this technique, three separate incisions are given in pars plana region. That is why procedure is called 3-port 20 gauge pars plana vitrectomy. The cutting and aspiration function are contained in one probe. Illumination is provided by separate fiber optic probe, and infusion provided by cannula introduced through third pars plana incision. Advantage of divided system approach includes smaller instruments, easy handling, improved visualization, use of bimanual technique, and adequate infusion by separate cannula. 23 and 25 gauge 3-port vitrectomy techniques introduced recently are becoming increasing popular alternate to standard 20 gauge vitrectomy. Advantages are include self-sealing sclerotomy sites, improved patient comfort, reduced post-operative inflammation, more rapid visual recovery. Vitreous substitutes. Vitreous substitutes are so-called tamponating agents are used in vitreoretinal surgery. 3-port pars plana vitrectomy using divided system approach: endoluminal light vitrectomy machine, suction cutter, contact lens, infusion, operating microscope. These two intraocular provide intraocular tamponade. An ideal vitreous substitute should be having a high surface area, optical glare, biologically inert. Current and vitreous substitutes in the absence of ideal are air is most common used internal tamponade, physiological solutions, ringer lectin, balanced salt solution, and be used after vitrectomy for endophthalmitis and uncomplicated vitreous hemorrhage. Expanding gases. These are used as 40% mixture of air. It is indicated for prolonged intraocular tamponade. Sulfur hexafluoride SF6. It doubles its volume and lasts for 10 days. Perfluoropropane. It quadruples its volume and lasts for 28 days. Perfluorocarbon liquids are heavy liquids which are mainly used to remove dropped nucleus or IOL from vitreous cavity, to unfold a giant retinal tear, to stabilize the posterior retina during peeling of epiretinal membrane. Agents used are perfluoro N-octane, perfluorotributylene amine, perfluorodecalin, and perfluorophenanthrene. Silicone oil allows more controlled retinal manipulation during operation, can be used for prolonged intraocular tamponade after retinal detachment surgery. Thank you.